We have a quorum. Please be seated. This is our May regular meeting of the panel on health services. If you are settled down, we'll go into the agenda. First, information papers issued. Since the last meeting, there are a few of them. I won't go into the details. If there are no particular views, we will look at the agenda for the next meeting. The administration has proposed to discuss the progress for the development of Chinese medicine hospital and strategic review on healthcare manpower planning and professional development. At the same time, members could see that different members had written in to talk about recent issues about organ donation and transplant, dental care, and also other crises. Members, would you like to add anything to the agenda of the next meeting? Mr. KWOK Ka-ki, Chairman, I think we want to discuss all these issues, but some are time limited. Say, for example, the audit report on dental services and the recent UCH incident. I know there is this agenda item which is somehow related, but I don't think it can take care of all the incidents that have happened recently vis-a-vis UCH and the impact on society. Can we add that in for the next meeting? Number one, it's very seldom that we discuss an individual incident at a panel, but judging from your letter and other members' letters, I can see that in the past few months, both in the public and private sectors, there have been medical incidents. The risk management and notification systems should be looked into, and I propose that we include this in our June meeting to discuss how the Bureau will look at risk management and notification system. And this is not just about the public sector, but both the private sector. There should be a paper coming from the administration covering both the hospital authority and the Department of Health. So there will be 3 items for the next meeting, and I hope this will become the first item for the June meeting. Okay, shall we deal with that like this? I am sure members are very concerned about the recent spate of medical incidents. We can't really discuss or comment on individual incidents, but as a panel, we are duty-bound to ask the administration what can be done about this, all right? I don't know what the administration plans to do with the Chinese medicine hospital and the manpower planning. I don't know how much time they will need, but if necessary, we'll extend the meeting to 7 p.m. Okay, that's it. And as for your item then on dental service, Mr. KWOK, we'll have to put it in the queue. We have talked about that many times, but nothing much has come out of it, so I will give priority to risk management first, all right? Okay, members, if you agree, this will be how we deal with the matter. Item 3 on the agenda. As you can see, we have this paper. We thank the Research and Information Services Division to have written this paper on rare disease policies. And this is about having an overseas duty visit to study the issue. This was raised by a member. It is said that we would like to go to other places to look at policies. I would emphasize we are not going to hospitals, but we are not talking about how to cure rare diseases, but how the governments tackle rare disease patients as a policy. We thank the Information Services Division and the Research Office for coming up with such good information. Members, would you like to ask the Research Office any questions? Because I have invited someone from the Research Office to come here. Dr. Pierre Chan. In fact, about rare diseases, the big problem is medication cost, not doctors' fees. Some pharmacists and also documents have told me that in other places there is also the difficulty to limit the pricing of medication by pharmaceutical companies. And the US and Europe have different ways and rules governing the setting of prices for medication. I think in Hong Kong we don't have any supervision or monitoring of the pricing of medication for rare diseases. Chairman, I hope we can add this point in. And I'm talking about medication cost from $500,000, $6 million, and maybe 5 years down the road it will be $30 million. And how we can tackle the sheer increase in medication cost. The research office, do you think you can get any information on this one? Thank you. The governments of different places should have different ways to deal with this. Okay, maybe Dr. Chan, if you have information, please also work together with the research office. Dr. Fernando Zhang, I'd like to thank the research office of the Information Services Division to have helped us. And in fact, from the information note, we can see initial information about subvention on medication. Mention has been made on this about different countries. I, in fact, would like to ask the research office a question. After reviewing so much information, if we really conduct this overseas duty visit and have discussions with government officials in other countries, which are the countries that we can learn mostly from? I have read the report in detail. I think the best example would be Taiwan because it's closest to us. Japan is also a good example. Geographically, it is most convenient to go to Taiwan and Japan, but the earliest that has made laws is the US, and the EU has, of course, a plethora of different ways of doing it. Sometimes they use policies instead of laws. Also, there is Australia, of course, which is in a different situation. Can the research office please make a suggestion? If we really form a delegation to go overseas, where do you think it's most worth our while to go? Chairman. Dr. Zheng has read the research report and he has already said that in fact different places have different policies. Let me talk about Australia first. The study scope is mostly on the research on medication. At this present stage, they are reviewing the criteria defining rare diseases. That is a review done by the Australian government at the moment. The federal government has commented on policies in the different states. So Australia may not be able to give us very comprehensive information at this stage. And the US is actually the first one to introduce laws to regulate the development of medication for rare diseases. And we can see from their policies that they target research and development of medication for rare diseases and also other kinds of research on rare diseases. Apart from policies, the US government makes use of its reform in their health insurance schemes to cover more patients with rare diseases. But the US is also reforming its health insurance scheme. And there may be an impact on the extent of protection for rare disease patients. We need to keep track of the situation. And then the EU is a little like the US. The system also targets the promotion of review and research into medication for rare diseases, and also other kinds of research on rare diseases. As Dr. Zhang said, there are some policy guidelines for member countries to follow to develop their own policies on rare diseases. 成員國啦。
Different EU member states would have regard to their own circumstances and come up with different responses. Elsewhere in Asia, Japan and Taiwan have rather comprehensive coverage. Apart from promoting the development of orphan drugs and relevant research in terms of social service and healthcare services, they have also covered such matters in the policies. So compared with other countries, these two have more comprehensive coverage. South Korea also covered development of medicine and healthcare services in their policies. And other countries don't seem to have policy to cover these matters. So it seems that Japan and Taiwan have comprehensive coverage and maybe can give us a good reference for our cases. I thank the research office for doing this very good report. We know that a citizen came here the other day telling us her story. Shortly after that, she passed away, leaving a child with the same rare disease. The report, the information note, provides information on several selected countries. The consensus in the community is that we are lagging behind many countries in terms of support for patients of rare disease. Is that true? Through our information note, you see that we have covered 6 selected countries, all of which have some laws on rare diseases. They have a system of designating orphan drugs for rare diseases. They promote the development of drugs and provide support to patients. So far in Hong Kong, we don't have the same. For example, the government has got no definition of rare diseases. Thank you. That's exactly the matter I want to raise. Well, we are very outdated in providing support to patients of rare disease. I want to ask something which the research office may or may not be able to help. Other countries are doing more and more to support patients of rare disease. Are we moving in the same direction? Mr. Kwong, we are not discussing an item on rare diseases. We are talking about a proposal to conduct an overseas duty visit to study rare disease policies. We want to learn from other countries, and would like the colleagues in the research office to put Hong Kong in that comparison framework. We know what we are doing in comparison. We are not discussing this information note as such. And please don't think that we are going to have a policy on these after reading the document, because those responsible for policy are not there over that side. The information note provides you with information so that you can make an informed choice on where to visit and whether there should be a duty visit to other countries, and if so, where. So the information note is provided to enable us to make an informed choice. So we may want to make some suggestions, some proposed direction of research. For example, Dr. Chan Pui-yin has said that we should look at the costs of medicine in the research. So we have a duty to tell them what to do. We have to give them, the research office, some framework for the study. Dr. Financial Zhang asked the research office to recommend possible destinations for the duty visit. I don't think they're in a position to tell us that. It's up to us to decide where we would like to go. And we're not having a discussion of the information note. So perhaps we can have a supplementary note from the research office. Let's have one more column on Hong Kong. And if we have everything in Hong Kong, then perhaps no need to have the duty visit. But if we have nothing here in Hong Kong, we can tell the government that we are not having anything, and other countries are having everything. Sorry for being so long-winded, because I want to stay focused. All right, Dr. KWOK Ka-ki, Chairman. I'd also like to thank the colleagues from the research office. There are two parts. First of all, whether these countries have laws on rare diseases, and if they have, how they deal with patients of rare diseases. And I don't suppose for a moment that the government doesn't have all this information. So if we are to conduct an off-duty visit, we have to ask ourselves what the purpose might be. The information note talk about legislation, and for EU is a process from 2000 to 2016, and the US is a developing situation. Can the research office please advise us on the major problems? And in Hong Kong, the sticking point is whether we should go for legislation. So I would like to know what the kind of problems are encountered in these countries in relation to legislation. Would like to convince the government the need for legislation, whether we have this duty visit or not. And second, on funding, I would like to know the changes in medical costs, in costs of drugs before and after legislation, and whether the definitions covered various rare diseases. Because of the difference in definitions, the burden on drug costs is also different. Would like to know how much more is spent on supporting these patients after legislation. In some countries, the legislation is narrowly defined, and therefore they are not going to support a lot of patients. and to meet drug costs. I would like to know more about the views of patient groups in the US and the EU on the lack of comprehensive support. All right, other suggestions? So the colleagues from research office, I think you know what members would like to get additionally. And we don't need to make a decision today. Some may want to consider whether more should be covered. At the next meeting, we'll have to make a decision. If we decide to go on a duty visit, then where? And the time for this will be October or later. Thank you. So that's all for item 3. We now move on to item 4. Let's invite the officials to come in.
我哋歡迎局長夏建偉醫管局團隊，咁我哋就今日咧講緊。
I'd like to thank all the attendees. This is an item on the new acute hospital at Kai-tak development area preparation works. So members, you may wish to indicate that you have some questions. So over to the Secretary for introduction.
好啊，多謝主席。係呢一個咧，第一個嗰個議題。
Thank you, Chairman. This is about the preparation works for the acute hospital at Kai-tak. In 2015, in the policy address in 2015, the plan to build an acute hospital at Kai-tak was announced to meet the needs for the demand for healthcare services and facilities in Kowloon. And in last year, there was the $200 billion plan for a 10-year hospital development program. For people living near Kai-tak, they have a keen demand for healthcare services. So there's an urgent need to build an acute hospital to serve people in Kai-tak and also in other Kowloon districts. For the longer term, this acute hospital would tie in with the facilities of the Kowloon Central Cluster and other healthcare facilities to meet the local healthcare demand. There will be 2,400 inpatient beds and daycare beds. It will incorporate more up-to-date and modern facilities and equipment, and that will be providing the Tier 2, Tier 3 emergency services, and there will also be other daycare and ambulatory services. And there will be a neurological service center to provide Tier 3 and Tier 4 to Kowloon Central Cluster, and they would the facilities there will share the neuroscience equipment, and this will also provide support to the adjacent Hong Kong Children's Hospital. Before the project starts, the HA would commission a consultant to carry out the preparatory works, including site investigation and ground surveys, design of the plan and tendering, etc. At money of the day basis, the preparation work would cost $1.15 billion. In the second quarter of 2017, the HA would submit an item to the Public Works Subcommittee for funding support, and in the third quarter to the FC for funding approval.
If approval of FC is forthcoming, our aim is to start the preparatory work in 2017, and the entire construction work is scheduled for completion in 2024. Hope members can support this project. That is to have a new acute hospital at Kai-Tak development area, so we can start the preparatory works as soon as possible. Thank you, Undersecretary. This is a panel discussion first, and according to ROP 83, if you have 83A, if you have direct or indirect pecuniary interest, please declare the interest before you speak. We have about 5 members who are speaking, 3 minutes each. KK Kwok. Chairman, I support the hospital, of course, but I'd like to ask a few questions. First, the cost. We have heard different figures. I'd like to know the latest figure, please. No matter how much it is within the $200 billion. And as you know, the more you spend, there will be less left for other hospitals. Number 2, since we don't know the future of QEH, once we have this NH in Kai-Tak, are you going to do away with the entire QEH? First of all, this is my worry, and this is also my objection. If both hospitals are in Kowloon Central, you have to answer one question, and that is, will there be a possibility for more patients to be able to use the resources? As I know people are fighting for turf also within the hospital authority, and I don't think it is something good. About the neuroscience center in Kowloon Central and Kowloon West, we understand you have these neurosurgery departments. I'd like to know whether they will be combined later. If not, it will not be very meaningful to have so many centers. And also the oral maxillofacial surgery center. Many mentally ill children and their parents came to us recently. As you know, they need the service of special dentists. They need general anesthetics and also MAC. If you don't have the space, they can't have the service. It is not available in the children's hospital, but you must provide this in this new hospital, because there are hundreds of thousands of mentally ill patients, and also some children who are physically really disabled, and they cannot go to an average dental clinic, and they need this special service. Will it be made available? If yes, what is the scope of the service? Undersec. Thank you, Dr. Kwok, for your questions. I'll kickstart, and then I'll see whether the HA would like to add. About the cost, this is $1.15 billion. And this is only for preparatory works, including site investigation. Exactly. I'm asking you for the overall cost of the hospital. Perhaps the HA can add, because it is a little difficult to provide an accurate overall cost, because the work that follows may need to be started first, and the HA can add. Secondly, the future of QEH. We said many times that when this new hospital is completed, QEH will be relocated to the new hospital, because QEH has to be redeveloped, and QEH will be temporarily relocated to the new hospital. And after redevelopment, what will QEH be providing? The initial view of the HA includes a big ambulatory center, and there will also be inpatient beds. But at this moment, we will have to see what the demand is at that moment. We haven't finalized the number of beds yet. So QEH will be there, and you can rest assured that QEH will be preserved. As the third question about dental services, we said before that in the past few years, NGOs and the Department of Health have conducted a pilot, and we are seeing how we can regularize that pilot. At present, the remaining cases that are in the queue will be attended to within the year, and in the interim, we will review the effectiveness of the pilot to see how it can be regularized. I have heard many people say that there should not be a means test. We understand that perfectly. No, Undersecretary. Sorry, Dr. Kwok. Sorry, Dr. Kwok. Allow her to answer because you have exceeded your time already. She hasn't got the chance to answer all your questions. If you are not happy, you can wait for the next round. I can defer to the HA. And also about the Neuroscience Center. Okay, about the Neuroscience Center, it will play a special role. It will introduce technical skills, and there will be R&D and also special arrangements for training. It may not be the only neurocenter for Hong Kong, but it has a role in providing some high-tech or state-of-the-art services. But we haven't gone to the detailed design stage yet. How much is the entire hospital going to cost? I can defer to Mr. Lee. Chairman, first we need to do the preparatory works, and that would include the detailed design, and only after that we can put our finger on a more accurate cost. But about 50 billion out of the 200 billion has been put aside for this project. But it also depends on the price trends of construction materials and also the overall detailed design of the hospital. Sorry, Dr. Kwok, you have to wait for your next round. Pun Xiuping. Chairman, my questions duplicate somewhat with Dr. Kwok's. I'm talking about the future of QEH. The Undersecretary mentioned that just now. Well, I support this NAH. I hope you will do it ASAP. We'll have this only in 2024 or 7 to 8 years later. This will serve the Kowloon Central Cluster. It will be much better, of course, if we can keep QEH because we can expand the volume of service. Have you assessed how the NAH will help shorten waiting time in future in Kowloon Central? Secondly, manpower. Well, 7 years will pass with a glimpse of an eye, but manpower is now already tight in many hospitals. How can you make sure that there will be people working at the NAH when it's completed? Undersecretary. Thank you, Mr. Poon. About KCC and how this hospital can shorten the waiting time and boost service. Can I defer to Dr. Zheng, Director Cluster Services? If we have a modern hospital, including modern hardware and equipment, we will have better quality of service. And as for quantity, after NAH is built, QEH will be relocated there, and there will be 400 more beds. In KCC, we have Kwong Wah Hospital redevelopment. There will be 350 more beds, and also Our Lady of Maryknoll Hospital will be rebuilt as well. So KCC does not only depend on this NAH. And I'd like to mention the future of QEH. When NAH is built, the team of QEH will relocate to NAH so we can redevelop the site. We haven't come to the detailed planning stage yet, but conceptually, the QEH will play two roles. One, it will remain in KCC. It will complement the work of Kwong Wah and Kowloon hospitals to provide service. And secondly, QEH will also play a role for the entire territory. The Undersecretary mentioned an ambulatory center. Since it is very conveniently located, it is right in the heart of the entire territory, and it is well served by public transport. And therefore, QEH will take care of the development of other clusters as well. What about manpower? I'm sure the NHA will earmark manpower for the hospital, because if you look at the completion date, it will be 7 to 8 years later, and I think the HA will be putting aside manpower for NAH. The HA? It depends on the number of graduates, but we are optimistic because we see a bigger class graduating now. Mr. Eunice Yong, 3 questions. Number 1, the use of the site. You say it will be subject to detailed planning, but when will a decision be made? The 8 hospitals will have to complement one another. The earlier we know, the better. If we know what services there will be at Kai Tak, and also whether the hospital will still provide its original services. It is said that the hospital service will be relocated to Kai Tak. How can you minimize impact on services? And if I can look at the plan, I see at Site B, since there will be 2 sites for the hospital, and the connection is to the east. It is a flyover instead of a subway. Will there be a subway to connect with Site B? And also, there are no bus stops or minibus stops for Site B. It may be difficult for the public to access Site B. Are you going to do something about this? Thank you, Ms. Yong, for the questions. Can I ask the HA to answer the questions on QEH? I think Dr. Cheung already said something very clear about that, but timing-wise, we have to take another look, because it's so many years later. Of course, we know there will be a demand for service, but the details will have to be gauged nearer the time. As for new services at Kai Tak, Dr. Low, would you like to take the question? About relocation, we haven't got the detailed timetable yet, but conceptually, since there are many beds, we will do it in stages. Acute services will be taken as a whole, and the non-acute services or ambulatory service will be taken together. Perhaps we will move the outpatient service and the oncology services, which is mostly ambulatory, then they can be moved first. But the acute services have to be taken together with the ICU and A&E department. So that will be the stages. But we'll have to do detailed planning as to how the decanting can take place. And the sites, Mr. Lee, Chairman. Our planning is done together with the Children's Hospital. At present, Site A and Site B are connected to the Children's Hospital by a subway. Why is there no subway between Site A and Site B? Because underneath Central Kowloon route, we will have to still rely on subway under the Children's Hospital to link up the 3 sites. They would be mostly used for the transfer of resources, but people will mostly use the overhead links or flyovers. There are 4 members waiting. Mr. Wu Chi-wai. Thank you, Chair. We all understand that the Kai-Tak Hospital will take over the A&E department and acute services of QEH. Under SEC, are you going to tell us that in fact the general acute services of QEH will all move to Kai-Tak? Can you confirm that point? Secondly, we are all very concerned about the future of QEH. Let me ask you this specific question. Can you confirm that the site of QEH will still be used for hospital purposes? And Under Secretary, are you going to redevelop the entire site, or are you only going to convert the buildings so we can understand?
And the third question is this. Well, we have to look at the transport network. If we rely on A-grade facilities, it will be rather tight because there's only an ingress at the gas station. So have you considered the transport needs when you have a cluster of hospitals here, and you are going to spend $1.15 billion on the preparation works, apart from the Kai-Tak Hospital, the new acute hospital? Are you going to cover other things? Because this is a big sum. Are you going to look at, for example, contaminated mud and its disposal? Because people might think that you're spending too much otherwise. Don't think that you can rely on the monorail, because the monorail proposal is controversial. We don't want to be imposed of the we don't want to have the monorail system imposed on us. That costs $20 billion. So what you would be doing to meet the transport needs with or without the monorail system? Well, the member is correct that when the Kai-Tak Hospital is commissioned, many services of the QEH will be relocated there. For the site of the current QEH, it would be used for the healthcare services. Whether it's a redevelopment or reconstruction, we don't have any concrete plan at this stage. For example, we don't know how many beds there will be, but the site will be used for healthcare services. Mr. Lee, well, the Kai-Tak area is under development, and so we need to rely on Cheung Yip Street for ingress and egress. Once the development has been completed, there will be a road network linking up the roads to the new hospital. And there is also a subway from Sampo Gong to this new Kai-Tak development area, so transport can be improved through such infrastructure. And we can also talk to the Transport Department on how to enhance existing bus and minibus services. We have not factored in the possibility of a monorail system. If there's one, we'll ask a station to be located near the hospital, the new hospital. What is covered by the $1.15 billion? Most will be spent on the consultancy services, the design, that is. A small amount will be spent on the site investigation. So it's spent on the new hospital, not on the site. Well, so it has got nothing to do with the ground condition, the contaminated mud, and so on and so forth. Please tell the FC clearly about this. Well, more than $1 billion on the design. Well, we'll talk about the Kai-Tak sports ground, and it covers much more Well, I don't know whether it's a lot of money for the design work. You may wish to reserve your questions at the Finance Committee meeting. With the new acute hospital, there will be the A&E service there. Will the QEH A&E service be suspended? I would like to confirm this first. At that point, the QEH acute A&E service will be relocated to Kai-Tak. Have you consulted the district councils and local people? Because not many of them know that the A&E service at QEH will be relocated to the new hospital. Well, I can say something, and then HA may wish to supplement. In the Kowloon Central cluster, apart from QEH, we also have KWOK Hospital, and I believe the different hospitals will act in a way to achieve synergy. Well, we need to expand the A&E service, A&E wards. You know that QEH and KWOK Hospital are close to each other. So in the new hospital, the A&E service will be expanded to meet local demands. So please tell us how KWOK Hospital can pick up what is left by QEH, for example, in terms of beds, and we would like to know how much of the A&E facilities or service will be reprovisioned in Kai-Tak, so as to assure people that there is no loss in capacity. It was previously said that in Phase 1 will be completed in 2021, Phase 2 2024, and at that point the A&E service will be relocated. And now it's said that everything will be covered in the first phase, but we are only told now of the merging of the two phases. If we have Phase 1, there will be 800 beds available in 2021. But under the current plan, it may mean that the first beds will only be available in 2024. Why don't you keep the two phases as previously suggested, Dr. Leung? Well, we have had repeated discussion in the HA. Our colleagues are more inclined to have just one phase instead of two, because it's not easy to relocate some of the hospital facilities and services while keeping some others at QEH, because the services are interlinked. So operationally, having two phases will be difficult to handle. Well, if you have two phases, the A&E service will be available in the new hospital in 2024. So you're not going to have A&E service in 2021. So when everything is completed, you're going to move the hospital in one go. But Mr. Tam is saying that if you have two phases, you are going to have 800 beds in 2021 after Phase 1 is completed. Well, that's only theoretically possible. If you have two sites, how can the healthcare workers provide the service? So we now want to have just one phase, which is what we want to achieve under a compressed timetable. That's operationally more desirable. You may think that with some beds available in the new hospital, we can use those first, but we cannot split the teams like that. So our people would have to work in both sides. And we have to bear in mind the need to maintain service quality. So our colleagues are very happy during the internal consultation stage that we are now going to have just one phase instead of two. Dr. Fernando Zhang, we always support building more hospitals because we don't have enough. And many hospitals are like wartime hospitals and ill-equipped. This new acute hospital is a super hospital. There will be a 10-year program costing $200 billion, and almost half of that number of new beds will be in this new hospital. But population growth is faster in NT North. And in terms of hospital services, they are already very much stretched to the limit. But only the 1,500 or 1,600 new hospital beds will be in NT under the new hospital program, and most will be in Kowloon. So my concern is whether the hospital services are developed in line with population growth. And this is a very big hospital. I don't know whether building a big hospital like this is in line with the global trend of hospital construction. We want to have healthy communities, so we need hospitals, but not super big hospitals. Rather, we would like to have smaller hospitals with specialties. And that's why we have this children's hospital, which is good, which I'm going to support. But next to it, we're going to have this super big hospital. It seems to go against the global trend of having community hospitals. Is it for your convenience? You have the money, you have the site big enough for this? Do you have any justifications to support building such a big hospital in Kai Tak? Because of the aging population, the HA conducted some studies apart from primary care, which require a lot of additional work. And there was this study to look into the number of beds and the duration of hospitalization for those in the age group of 80 to 85. So they have come up with some numbers on of beds required, and we have a lot of expansion projects and redevelopment projects for hospitals, and that's why we have a secure funding from the FS for the 10-year program. Dr. Zhang refers to the surface demand in the NT. Actually, the surface demand in Kowloon is also big. The HA has conducted a study into this before they come up with this new acute hospital proposal. And there are different hospitals in the Kowloon Central clusters serving different needs. But this new acute hospital is not a local or district hospital. QEH is also not a district hospital. It's the Tier 4, the hospital serving a big territory. On Hong Kong Island, we have the QMH, and in the NT, the Prince of Wales Hospital are serving similar functions. So QEH is not, this new hospital is going to provide service to a wider region. And in the new children's hospital, there's no obstetric wards. And this new acute hospital is going to support the children's hospital. And children's hospital is a new specialty. And also in this new hospital, we're going to have a neuroscience center. So apart from meeting the demand of local people, it also serves the Kowloon Central Cluster.
There are also development plans in the NTN, Hong Kong Island, that will use the $200 billion sum. But we will also have to explore into demand in the future, and expansion will probably take place in the NT. But you are not taking care of NT. Dr. Fernando Cheung, perhaps you can leave your questions to the next item on Prince of Wales Hospital. Let us have Jonathan Ho. Thank you, Chair. This is called a hospital for Kowloon Central, but actually it's very close to Wong Tai Sin and Kowloon East. Its entrance is on Kwun Tong side. Redevelopment of QEH will be taken jointly with NAH at Kai Tak. The entire QEH will be relocated to Kai Tak. If that's the case, will there be space or room to take away some pressure from Kowloon East cluster? You only have the leading hospital, which is UCH, and UCH is under huge pressure. And doctors who are under pressure may not be providing the best service at all times. How can you quicken the construction of QEH so as to take away some pressure of Kowloon East? You said the completion date would be 2020 in the first instance. Thank you, Mr. Ho. Maybe the HA can comment on this. When we have the Kai Tak Hospital, then with Our Lady of Maryknoll Hospital and Wong Tai Sin Hospital, we are going to work on them as well. You remember Our Lady of Maryknoll Hospital has been included in the PA for redevelopment, and the HA will also be rolling out different programs. And as you know, perhaps a Kowloon Hospital is also to be redeveloped. The HA, certainly we want to hasten the building of Kai Tak Hospital, but that still takes time. And Kowloon Central or Kowloon East is also developing its service. UCH is being expanded, and the Haven of Hope Hospital will increase its bed supply, so there will be more services also. After Kai Tak Hospital is completed, it will certainly convenience residents in Kwun Tong. Some patients will use this Kai Tak Hospital. We hope, therefore, in the future, Kowloon East Hospital development will concentrate in Chung Kwan O, which will see a growing population. And we are thinking there may be another expansion program in Chung Kwan O, and we can further boost service in Haven of Hope. Chairman, can I add about the road transport? Trunk Route T2 should be the main road, but the Central Kowloon route will be completed only after Kai Tak Hospital is built. You have to think about the transport complement in more detail. Mr. Shu Ka-fai. Thank you, Chair. About the NAH in Kai Tak, I support it wholeheartedly. There will be a lot of residential development in Kai Tak, and old districts like Kowloon Bay, Kwun Tong, Kowloon City. I believe elderly people in these districts will increase in number, and if they have a hospital nearby, it will be good for them. A lot of resources are being plowed into the project, but it's still not enough for our population, and we also lack doctors. But we, of course, support the building of more hospitals. I don't have a question. I just say I support this. Thank you. Fernando Zheng, second round, 3 minutes. Thank you, Chair. You say there is a demand in Kowloon, but the demand is bigger in NT. The waiting time for specialist care is longest in Kowloon, in NT East and NT West, so it's not fair just to talk about Kowloon East. I wouldn't object that there is demand in Kowloon, but NT is in a worse situation. We are going to talk about the Prince of Wales Hospital. There will be 450 beds more. But it's just a small fraction of Kai Tak. In Kai Tak, there will be 2,400 beds. But you have to subtract the original beds from QEH. Well, that is what I understand from the team. Planning-wise, and also the cost, they are unimaginably high. You are talking about a price tag of $50 billion. The Tung Chung Hospital was completed in 2014, 2.5 billion. Tin Shui Wai, 2016, 3.9 billion. And the Children's Hospital, 13 billion. This is being built. Why is it that Kai Tak Hospital will cost 50 billion or even more? This is quite alarming. You are using a quarter of the 200 billion earmarked. Yes, I know there is a big number of beds, but there should be an economy of scale. You should not have the same unit cost for beds if you add 2 or add 10. Can you tell me your budget of $50 billion? I'll ask Mr. Lee to explain. But that is only a ballpark figure. Mr. Lee only gave you an estimate. We really need to see the contract and the final bid before we know. Maybe Mr. Lee can let you know the basis for his estimate. Mr. Lee, Chairman. The project cost depends most on the area the project will occupy. We are talking about 400,000 square meters of building area. And if you talk about the North Lantau Hospital or the Tin Shui Wai Hospital, they occupied only 40 to 50,000 square meters. And we'll have to factor in inflation in the next few years. And the cost should not be regarded as particularly high. Dr. KK Kwok, second round, 3 minutes. Chairman. You say the construction cost, material cost will require that kind of money. I think we need more information because we are very worried about this common feature of overspending for all projects. 50 billion is not a small sum. We don't want you to be squandering money. Number 2, it seems you already have a plan for the $200 billion, but it has never been announced. Next time at the PWSC, we need more information about the different uses for the $200 billion. Then we will know whether your project sum here will affect other hospital projects in the queue. And I am not worried about the proposed dental services. That is the barrier-free dental service. Well, what you are doing is not satisfactory. You are borrowing the service from the evangelical hospital, but this is only a makeshift arrangement. There are children who are mentally or physically disabled. They need general anesthetics in order to receive dental services. It will be good if such children can be taken care of at the children's hospital, but I don't think there is a plan for that to be done. And also, whether it be adults or children, those who are mentally disabled need hospital services in order to receive dental services. I'd like to ask you whether you can provide them with the service, especially with dementic patients. They have no choice. The normal person can go to a clinic for dental services, but these people can't. How can you allow these patients who cannot cooperate with you to receive dental service? Every dentist knows they have to be put under general anesthetics and they have to rely on the public system. This is a separate thing from expanding or not the public dental service, because these people have no choice. I am saying this Kai Tak Hospital and the Children's Hospital should both provide this service. Dr. Zheng can answer the question. We can explore into this issue. The dental service is mainly provided by the Department of Health. I know some cases have to be hospitalized, and different hospitals do provide scattered services. But we can talk to the Department of Health if this kind of service is developed, because it's not provided by us. Where the DOH would like it to be, maybe at Kai Tak, maybe at other hospitals. But we need to start an exploration with the DOH. Okay, we have had a thorough discussion of this item and I haven't heard any objection. There will be other occasions when we can take up these questions again. Thank you very much. Next item. Redevelopment of Prince of Wales Hospital, Phase 2, Stage 1, preparatory works. We still have a third item on inpatient medication order. We can extend the meeting to 6:45 if you do not object. Thank you very much. We'll ask the next team to come in. And then, Underset, would you like to say anything about the paper? If not, let's go direct into questions. Well, yes, why not? If members don't need an introduction, then we can go directly into questions, because everything is in the paper and it is taken as read. 3 minutes for each member. KK Kwok, Eunice Yong, and Poon Siu Ping. Dr. KK Kwok, I support redevelopment, but I have a technical question. In Kowloon East, we don't have convalescent services. Shouldn't we take the opportunity to include this in PWH? I know there will be A&E, ONG, and also pediatrics. That I understand, but since this has a big footprint, are you maximizing the plot ratio? If not, shouldn't you maximize the plot ratio to include convalescent services? This is what is done in Chuen Mun Hospital as well. The convalescent block is placed next to the main block of the hospital. In NT East, apart from Sharton Hospital, we don't have any other hospital providing convalescent service. If you do not have good convalescent service, people cannot be discharged. Also, in the main block, if you provide A&E, you will have to do a lot more. But if in the main block, you can turn some services into convalescent because it only requires lesser preparation, so people don't have to wait so long. You are preserving A, B, C, D, and E and F are to be demolished. But you can take down the Li Ka-shing outpatient clinic, the hostels, or the quarters. And can you do that then? Thank you. From the paper, you will know that the redevelopment of PWH is in 2 phases. For phase 1, that will be to take down the lecture theatre and the quarters in order to build a new block. In the second phase, there will be demolition of the hospital old buildings group and to build an oncology center and an ambulatory center. Mr. Kwok talks about convalescent service in Kowloon East. Can I defer to Kowloon East colleagues to talk about it? Thank you, Chair. In Kowloon or NT East cluster, apart from Sha Tin Hospital, there are not too many beds, but we have a plan to go for a minor works project to increase the number of beds.
And in Taipo, we also have these beds. Or the Cheshire Home in Sha Tin and Taipo Hospital are providing such beds. Under the NTE's clinical services plan, when we build an new acute hospital, we will have a convalescent and rehab wing so as to provide continuity of treatment from A&E to convalescence. And Dr. Lee is doing the design. So I'm talking about intermediary convalescent services. When they are admitted, the patient is admitted, it's acute, and after a few days it may be downgraded to subacute, and they can then go to the rehab wing. So this is covered in the clinical services plan. For the design, the hospital would facilitate the entire process. As to the number of beds, is subject to more detailed planning. So we look at this in the design, and for example, how many to be put in the hospital for all these subacute discipline and specialties. Ms. Eunice Young, I support a plan. After the redevelopment, the number of beds will increase by 450. Can there be more? I've heard that there are other possibilities. I've heard that some male patients have to use facilities designed for female patients. And the waiting time for A&E is very long. It can be up to 8 hours. Will the waiting time be reduced after redevelopment? And there's a car park to be demolished, to be taken away. Can there be more spaces for the ambulatory patients in the new car park? I'll ask the HA to talk about waiting time and Mr. Lee to talk about parking spaces. Dr. Low, the waiting time at the PWH is rather long. After the redevelopment, we are going to have a bigger hospital with more manpower. We believe the waiting time can see some improvement. We're going to have additionally 450 beds. That's in the stage 1 of phase 2. We also have stage 2 of phase 2. Another 400 beds will add to the total. The entire redevelopment program of PWH will see an increase of 850 beds. Parking spaces. But the site has a big footprint. Some parking spaces will be lost during the construction phase. We can provide additionally 50 to 60 spaces in the Sha Tin Hospital. Well, that's very far away, says the chairman. Some of our people will be working in Sha Tin Hospital during the redevelopment. Let me ask a follow-up question. Doctors and nurses may have to work at both hospitals. Very rarely would they take a public transport because they need to rush for urgent cases. Mr. Pun Siu Ping, I, of course, support the redevelopment of PWH. You are going to demolish staff quarters, blocks A, C, D, and E, and some arrangement will be made at Sha Tin Hospital. Another member has asked questions about parking spaces. It will take a long time for the entire project to complete. It's up to 2027. I don't know whether you can provide shuttle bus service between PWH and Sha Tin Hospital for your staff. After the redevelopment of PWH, what will be the new arrangement for the services provided at the Sha Tin Hospital? Would there be staff quarters, or would there be new uses? And we're also concerned about the impact on the services during the redevelopment, including the problems arising from the construction, air pollution, and so on. Dr. Low first, and then Mr. Lee. Staff quarters, blocks A, C, D, and E will be demolished. These are staff quarters, so clinical services will not be affected. At Sha Tin Hospital, we have a decanting block for non-clinical backup staff. For transport arrangement, if they have to go to PWH for meetings, we would arrange transport for them. And then I think I can defer the other questions to Mr. Lee on nuisances during the redevelopment, such as dust, vibration, noise, and sewage. We're also concerned about these problems. We have stringent requirements that our contractors would have to comply with, and we have been able to manage properly all these problems so far. Well, I support the second phase of the redevelopment of PWH. When I meet government officials, I would always repeat my request to expedite the redevelopment. Well, after this is done, after redevelopment is completed with the additional beds in place, can the needs, the demands for services in NTEs be met? Would there be in the future further expansion plans? And would there be sufficient healthcare manpower to tie in with the redevelopment? Thank you, Dr. Kwok. I can say something about the overall manpower situation. From the time we start to the end of the redevelopment, when 450 additional beds and 400 additional beds will be available in phases, there will still be a sufficient time for HA to provide training and to recruit sufficient manpower to provide the services. Dr. Low will talk about NTEs. Well, we have a typo Sha Tin and these hospitals will support each other. When PWH is under pressure, North District hospitals and Typo Hospital can provide some support to relieve the pressure. Apart from PWH, there is also an expansion project for North District under the 10-year program. Additionally, 600 beds will be added to the capacity. So for the NTEs, would pay attention to the growth in service demand and population. Having considered these factors, we are optimistic about the future. And apart from the number of beds, the service modes are also important. We will pay attention to service development. In Stage 2 of the redevelopment of PWH, we would provide more ambulatory care facilities to meet the increasing service demand. Dr. Chen Pui-yin, thank you. To follow up a question raised by Ms. Eunice Young, every time when a hospital is redeveloped, we have problems with car parks. Car parks are not just for the staff. I know that in some hospitals, very few parking spaces are provided for visitors, not just for staff. I think the constraint is because of the plot ratio of this site in question. We are going to see redevelopment projects introduced for different hospitals. That may be an opportunity to improve things. I know you have to seek approval from the town planning board in some cases. Can we review the constraints imposed on parking spaces of hospitals for both staff and visitors? I know there are some constraints imposed by the ASD. Well, the planning department has promulgated some guidelines, and the basis is the number of consultation rooms and facilities. In the past, they were rather tight. They were rather tight in imposing such conditions. I know that there are bound to be problems, but it would be better for the government to raise these issues rather than asking staff to do this. Well, the planning department guidelines were promulgated decades ago, and now we have redevelopment plans. We would like to seize the opportunity to improve the provision of parking spaces. So such redevelopment programs afford us with opportunities to make changes to the town planning department guidelines. We are now concentrating more on ambulatory care services. So perhaps the basis of car park provision should not be just hospital beds. Of course, I support redevelopment, and we like to have more beds and more facilities for A&E and psychiatry. My concern is that earlier this year there was a corruption case about this project, involving $60 million. The total cost is $1.3 billion. Is it going to cost $8 billion at the end of the day or more? It's even Ki-Tek is going to cost even more. We are willing to spend the money, but we need to take care of management, efficiency, and so on.
檢討一下。
Maybe DHA should review its arrangements for financial management and control. And for this one, there will be 2 stages. Will this initial estimate of $8 billion be close to reality, or is that just for indicative purposes? What will be the overall final cost? And Mr. Lee. Chairman. The news report is being investigated by the ICAC. We don't exactly know the progress, but that is a minor works project. And for such capital works, we have very strict control. The ASD is the vote controller, and they check every penny spent. This is a totally different operation from the minor works project, and I like the member to be reassured. Whatever we spend, we have to get the approval of the ASD. Would the $8 billion be a final figure? Well, I don't know where it has come about. I haven't heard that figure. What is your cost estimate for both phases? We're talking about phase 2, stage 1 of the redevelopment project. It will cost about $30 billion. We are putting aside $30 billion. Even for stage 1? Okay, what about stage 2 of phase 2? Stage 2 is not in the 10-year plan. The 10-year plan only includes phase 2 of stage 1. In other words, the $30 billion will come from the $200 billion. Yes, that's correct. Understood. Any other members? Okay, members have asked questions on this one, and I think members are concerned about 2 points for both projects. One, we need supplementary papers from the administration on the $200 billion and how those will be spent. I think you have to have the information for FC. And you are already spending $80 billion out of the $200 billion already. Get the paper ready for us to know how you are using the $200 billion. I haven't heard any objection from members. Okay, we'll wait for you to go to the committees. Item 3. Well, this is the last item, or item 6 actually. The third item for discussion is the inpatient medication order entry system. It's a computer system. We'll ask the administration team to get ready.
I
understand there is a PowerPoint presentation. Well, it's good that we have something to watch. I'll allow you to do the introduction. Okay, I'll say a few words. The HA is implementing the Inpatient Medication Order Entry System, or IPO. In 2013-14, this was first implemented as a pilot in an HA acute hospital. Before catering for inpatients, the clinical management system could cater for medication processes of drug prescribing and dispensing for outpatients and discharged patients only. For hospital inpatients, clinicians and nurses had to prescribe drugs and document drug administration through handwriting, while pharmacists could only vet medication orders and dispense drugs against paper records sent to the hospital pharmacy. Therefore, in 2009-2010, the HA kicked off the development of IPMO with a view to enhancing clinical safety and improving clinical workflow efficiency in the medication therapy management of inpatients. In recent years, the IPMO has selected oncology pediatrics to start clinical pharmacy services. At present, clinical pharmacists have become part of the team for clinical management of patients. Next, we will talk about the operation, the latest progress, and future development of IPMO. Can I ask the HA to introduce that? Is it for the lady to do the introduction? Yes, please. Chairman, members, we are introducing now the progress of IPMO. Dr. Pang. First, the background. Before we had the IPMO, clinicians would use handwriting to write on prescribed forms to do prescription. Nurses would use these papers to record prescribed medication, and then pharmacies will receive these papers and then vet the prescribed drugs done by clinicians. This workflow has caused some concern. First, the readability or legibility and accuracy of information on these papers. When we vet or look up these records, the drugs require timely management. And scheduling is required. But then with IPMO, doctors will use this system to deal with patients from the very first meeting with patients and throughout the hospitalization process. The IPMO will direct the information to the pharmacy, so the pharmacy can vet the drug prescription directly, and so there can be the vetting of information by different members of staff. We have introduced a barcode, and the distribution of drugs can be checked by scanning the barcode to verify right drug and right time. And then the barcode will be scanned again on patient's wristband to verify right patient. We expect some benefits from this system. We like to reduce medication transcription and administration error. We like to improve efficiency. We also like to streamline workflow for doctors, nurses, and pharmacists. We would like to improve communication among caregivers. Also, we want to improve medication documentation. Progress update on IPMO. In 2013-14, a pilot was conducted in Princess Margaret Hospital. And then in 2014-15, the system was launched in Chung Kwan O Hospital, PWH, and North Lantau Hospital. In 2015-16, the system was also extended to UCH, Ratanji Hospital, and Yen Chai Hospital. In 2016-17, the system was adopted in 5 hospitals, including North District Hospital, Pamela Yode Nathasol Eastern Hospital, Alice Ho Mu Ling Nathasol Hospital, Pok Oi Hospital, and Characters Medical Center. The way forward for this system is that in 2017-18, This will be rolled out in the remaining 3 acute hospitals, including Tuen Mun Hospital, QEH, and QMH. Kwong Hospital will implement the system after redevelopment. And then in 2018-19, when Tin Shui Wai Hospital and Hong Kong Children's Hospital start their service, they will also implement the system. Before 2021-22, we'll roll out the system to non-acute hospitals, 22 of them in phases. And at the same time, we'll enhance the system to support high-risk clinical settings such as oncology, pediatrics, and the ICU. And we will also develop a chemotherapy module under IPMO to facilitate provision of integrated care and support closed-loop medical process for cancer patients. This is my report, please. Members can now ask questions. 3 minutes. 4 members are waiting. Dr. KK Kwok. Recently, there have been different incidents with medication, the latest one being the one at UCH. I'd like to know whether this IPMO can help frontline medical staff. Say, for example, let me cite this incident as an example. If there is this medical record, and if some people have to make use of special drugs, including steroids or other immune system suppression drugs, or drugs that may hurt the immune system, including cancer drugs, and there may be interaction amongst drugs. Can this system help and detect such? Number 2, usually you need a lot of manpower to deal with a new computer system, and this will be no exception, and frontliners will have a harder time at the beginning. After using the system, how much time will frontliners take in order to adapt to the new system? As you know, patients are also complaining that doctors now look at the computer screen instead of look at patients. This is already featured in a film. And later on, even prescription is done on computer. Will it be that doctors will spend more time with computers instead of with patients? And blunders may not be reduced either. So how can you assess whether the system is successful or a failure? And number 3, how much money would this cost? Under Secretary. Thank you, Chairman. Thank you, Dr. Kwok. As was said, this is for prescription, scheduling, and also administration of drugs. May I defer to Dr. Zheng to give you more details? This IPMO is part of the CMS, Clinical Management System. As we said, this is about medication prescription, dispensing, and administration of drugs. And the member may be more concerned about the CMS and what functions there are to help doctors understand the special situation of a patient. I can now defer to Dr. Pang to tell you about the alert system within CMS. Will there be anything popping up on the screen? I'd like to add that in our CMS, there is an alert system. It's a platform for doctors to input patients' information in 3 categories. 1, allergies, negative reaction, and 3, clinical alerts. When a doctor prescribes medicine, the system will alert the doctor to previous allergies and also negative reaction to drugs, and the doctor will be alerted to make clinical judgment and also to sometimes go back on records. And as for the clinical alerts, there are 6 categories. 1, clinical situation, medication being used by the patient, clinical assessment, and even some medical protocols. If such records are input, then when the CMS is used, the alerts will pop up on the screen.
嗰啲人手會唔會用？
About manpower, are they going to use more time to deal with IT? Doctors would, of course, use this to give out prescription, and mainly the nurses would be have to adjust to this, and now they have the paper form prescription which will be given to the pharmacy. Under the new system, the doctors will use the information system. I'll defer to my colleague on the implication for nurses. When the new system is commissioned, nurses will need time to get used to this. But once they are accustomed to this, it's going to be more efficient and it's time-saving and, of course, safer. As for the pharmacy, the implication for the pharmacy, Ms. Lee, well, this will increase our efficiency. We used the MAR, the paper form MAR in the past, when we have to input our system one by one before the medicine can be dispensed. And now it's done electronically. And the scheduling of the dispensed drugs is already done. And we will know which drugs should be dispensed first. So the time taken will be shorter. We have been implementing this over a number of years, and I can, of course, supplement more information after the meeting. I think those who are sitting here have not used the system. They may be drafters of documents only, but I've been doing this every day of my work, so perhaps they should interview me. And I know what the alerts are about. The so-called pop-up alerts have to be inputted first manually. So I've contacted Mr. Zhang, and here are some of the issues that you need to pay particular attention to. So that's the alert, which require human input first. Well, the IT is there to help people work better. And I write blogs. I'm a blog writer. But in the HA, these devices are making us less efficient. For this email system, a number of colleagues are using the system. Definitely, the efficiency of the dispensary, the pharmacists will be better. But for doctors, doing the rounds in the wards, it's going to take us more time. We have to use the computer to look at the drug record. And the biggest problem is faced by the nurse. I know they have to learn how to use it. I don't know whether the nurses have told you this. They are shouting for help. I'm not trying to stand in the way of technological progress. But I have to say that these systems are meant to improve efficiency and make things safer, but sometimes the opposite happens. Whatever system we have, the doctor and the nurse will have to be accountable to the patient in question. These systems are playing a supplementary role. Ultimately, doctors and nurses are responsible for the care of the patients. They have to ask whether the patient has got any drug allergy and other problems. I thank Dr. Chen for his opinion. The HA is trying to computerize different work systems so as to make it safer and efficient. Of course, in the initial stage, people have to get used to it. And I think HA is just doing this to move forward. Dr. Zhang may want to supplement. Yes, now you have to look at a lot more information in the consultation. If a doctor, a lot of information must be read first. You need to spend more time in clinical duties to know better, to know the patients better. Well, we can make this easier by providing electronic and computer systems so that the doctor doesn't have to try to find information here and there. Well, even university undergraduates know that there is such a system. Is this going to be more time-consuming? Mr. Poon said, well, it takes time to get used to it. But is it really time-saving? We pay attention to any difficulties encountered by our colleagues. If so, we will try to help them. For new hospitals, we would provide a 3-hour training course to colleagues before the hospital is commissioned. The training is about hands-on skills, and we also have people helping them overcome the operational problems. Dr. Pang, have you received complaints from staff in all those hospitals? I want to respond to the points made by Dr. Chen. The time taken to do the rounds may be longer, but doctors also think that we can now better avoid errors arising from having written the transcription. And nurses also benefit from the use of the barcode and the dispensing process is more accurate. It makes sure that the patient is given the right medicine at the right time, so safety is enhanced. And we can also trace the prescription history in the system instead of reading the handwritten prescription records of doctors. So everyone have to chip in, and together we can improve safety of dispensing drugs. And we have regular meetings to help the 3 groups of colleagues in improving the workflow. Well, according to you, this is really fantastic. Have you got any data? You have been doing this for 3 years now. For these hospitals, have you got data showing that there's a decrease in drug incidents? You can provide supplementary information after the meeting. Have you got any data on the reduction of errors for the 3 groups of healthcare givers? Have you received complaints? Whether we're talking about prescription by doctors, dispensing of drugs by pharmacists and nurses. You're going to launch this to more hospitals, Tuen Mun, QEH. Well, you talk about the deficiencies in the past. Have you seen improvements after the introduction of this system? And have any of them proposed adding some manpower because doctors have to spend more time? Or perhaps it takes more time for nurses to provide care to patients? Can you give us any supplementary information like that? Dr. Peng can talk about transcription errors or prescription errors. Well, there's a small-scale interim review on this. We look at some data from 3 hospitals and their pharmacies. One of the biggest error reduction is transcription error. With the new system, colleagues at the pharmacy don't have to do any transcription, so we have been able to reduce transcription errors in terms of drug allergy and problems with interaction of drugs have also been reduced by the introduction of this system. When this is launched in all acute hospitals, we would like to carry out a large-scale review to assess whether the original objectives have been achieved. So we started with the pilot schemes, and over the years we have gradually phased the system in, and different colleagues have different needs and functions that they would like to have. We have been able to make improvements from desktop computers to laptop to a mobile app which can be used on an iPad, so that the doctors can use an iPad to know about the drug prescription history and to make changes on the spot. So that's what we have been doing in improving the system after hearing the comments from doctors. And nurses want to follow a strict protocol. For example, the dispensing process must be handled by 2 nurses, so as to make them assured. I've heard that in some hospitals there are problems in the teaching of nurses. We are now discussing with the universities. So perhaps we can provide some training software or or demonstration courses, so that the students and the teachers can handle the new system. Sorry, Dr. Fernando Zhang. We will end at 6:45. I've read the paper. Theoretically, such a new system can improve efficiency, make the system safer, reduce transcription error, and it can also provide alert messages.
There are a whole range of benefits, but all these is only theoretical. Have there been actual improvements? I can't see any statistics. You said you did an interim review. Can you not let us have the interim review report? Transparency is important. We won't hold up this good deed. We'll certainly support you, but we need evidence. This is a major system, and you must have done some review. Plus, Dr. Pang said after it is fully implemented, you'll do a review, but that is not the way to do reviews. The review must have been designed before you implement it, so you can compare the before and after situations. Or else you will just say that after everything is implemented, the system is well received. Well, this is called the inpatient medication order entry system. But many of your patients are not inpatients. They may visit the A&E department, but they are not hospitalized. And then they can queue up for SOPC. And there are a big number of such patients. Is it that these patients will not be included in the system? Or is it that you have to bring other systems in line with this new one? Or should the same system include all other patients? Also, I think one important thing of this system should be to increase or promote communication between patients, relatives, and medical staff. If you can allow the carers of patients to understand the use of the medication, and the system can reflect the reaction of patients and also carers' views. If there can be a complete record, the prescription can be done more appropriately. Can the system handle that? Undersecretary. Thank you, Dr. Zhang. We can give you the information on the review later. As for other questions, Dr. Zhang, first of all, outpatient clinics. In fact, the system has always covered outpatients. We have had that system for outpatients for many years already. And after we have included inpatients, the system will be complete. Now, of course, we'll have to continue to improve the system. And we are working very hard on that. And also, I agree with what Dr. Zhang said about carers' families. We are doing this on two levels. One, on the drug bags, there is a barcode. Once it is scanned, all the information about drugs and the side effects and everything can be seen on a smartphone. But you have first of all download an HA apps. And secondly, this is being looked into. When patients are discharged, they will take away a lot of medication. How can we then let the carers know more about the medication? We are working very hard on this. We hope that within the year, we can provide drug information to patients' families. And also, if members have to come back for MRI, CT, or even stomach endoscopy, we can work on that to see how the information can be given to patients upon discharge. If we can have a complete or comprehensive computer system, we can include all this supplementary information to help medical staff as well as patients and their families. Mr. Poon Siu Ping. Thank you, Chair. They have answered many questions already, but the system should be to convenience the public and reduce the possibility of blunders, so patients will be better protected. But Dr. Chen was saying that it actually makes work slower, and I think that warrants our concern. I want to know more about this. This is an IPMO. Is it that the system can be included in the EHRSS? Secondly, you said by 2022, the system will also be launched in 22 non-acute hospitals. That is, by that time, all government hospitals would have been covered. Since it is a good system, why can't you quicken your work? Is it because of resources? You said you would answer that question later. And will this system be promoted to private hospitals? Would that be one of your objectives? Because theoretically, the medication can be used by patients in different hospitals. Thank you. Undersecretary. Sorry, members. Some other members have come back. If you do not object, we can extend the meeting to 7 o'clock. Thank you, Mr. Poon. Your first question asked whether the information will be fed into EHRSS. The answer is in the affirmative. As to whether this can be promoted to other hospitals more quickly, the HA says they need resources from the IT Bureau for the system to expand. Now, of course, we would like to extend it to many hospitals, but we are still developing the system, and we face different environments, say acute hospitals, psychiatric hospitals, or convalescent hospitals. There are different situations. Dr. Pang can comment on the factors for consideration. Every hospital is different. It may be an acute or psychiatric hospital, and they put emphasis on different things. But even before that, when the system is to be introduced in hospitals, there has to be some infrastructural change, because we have to use electronic equipment. The network must be good enough to accommodate that. We also need to provide hardware for doctors and nurses. There has to be a procurement process, and before introducing the system, hospitals have to get prepared, including training of manpower. We need to work according to timetables and plans. And when we introduce the system to different hospitals, we have to dovetail or interface with the situation in different hospitals. What about private hospitals? The answer is in the negative. Mr. Charles Smock. Chairman, there was mention of an apps, and Dr. Fernando Zhang said he hasn't heard anything about it, and I surfed the internet and I could find it. I found it. But maybe you did not publicize your apps well enough. You may have to step up your publicity. About this IPMO, it is part of CMS 3. It is a major component. Many years ago, I was a member or chairman actually of the steering committee to develop this. We were responsible for the technical side more. As to the implementation and functions, my feeling is that many systems used under CMS were steered by the requirements of doctors. And my impression working with the hospital authority is such that since doctors, first of all, think about what they need and they did not first depend on IT people who would write the program. But since it was steered by you, the result should be better. However, sometimes we do hear the views of doctors like Dr. Pierre Chan. So my first question is, now that you have the system, and the same can be said about other systems as well, how can you allow frontline users, especially doctors, and also nurses, and in this case, you include pharmacists, how can you make sure that their reactions and views can be incorporated, because you can't please everybody with the same system? And also members mentioned data. Can you collect more data so that when the system is being implemented, you can see the improvements or otherwise, or even other aspects of the system? I encourage you to think about what data should be collected. It's not just the time. Well, yes, Dr. Chan said more time had to be spent. That is one aspect. But what about blunders or mistakes? Well, you know better what kind of data are worth collecting, and so you can do big data analysis. And number 3, sorry, Chairman, I am long-winded. Recently, there has been omission of prescription of drugs and wrong prescription of drugs, and this is not about inpatients, of course, but can there be functions in your systems which can check back inconsistencies? Say, a situation should have been handled. In other words, even if you have omitted something at the moment, you could still dig up the data afterwards. Well, the best is for instant alert. I don't know whether this has to do with artificial intelligence, but can that be part of your systems? Thank you, Mr. Mok. We said just now we have done a review, and the review included data collection and communication with the 3 groups of users. Dr. Pang? Dr. Pang, please repeat your answer. But let me supplement something first. I don't know whether you know that Ms. Pang is actually a doctor. I like to emphasize that because this is user-steered, user-oriented. If you don't know who the users are, the system cannot benefit them. So we have got this user-oriented system. We have collected the views before designing the system. Dr. Pang understands users because she has a clinical background and she understands the operation of the entire system. Dr. Pang can comment on data and functions. I'd like to give more information to members. We have heard the aspirations, and then we started a pilot, and then we developed the system gradually. In every hospital, we have teams, including frontline doctors, nurses, and pharmacists. Their views have been taken on board on that platform for the enhancement or improvement of the system in order to facilitate their work. Coming back to the review of the system and whether there has been any improvement. Actually, before we conducted the pilot, we did some research into possible errors of drug dispensing and prescription. And we also checked how doctors prescribe drugs on paper, dispensing on the basis of paper, and vetting of the papers.
We have compared the processes before and after the system. And obviously, we have seen improvement in terms of transcription error. What about the functions? Can past mistakes be traced by the system, or would you consider doing this in the future? Well, if we are going to improve the functions, we would like to prevent the errors rather than trying to find errors afterwards. And of course, computer system is not a panacea. We need to talk to the people to handle challenges and problems. As Dr. Chen has said, it's not fully automatic. The input has to be provided by someone. It's not a database input system. If it's a database and the input is automatic, of course you can check the message. And very often it would take a healthcare giver to interpret the report and then input the information into the clinical system. And how can we transform something in writing into something for the database? Well, we all know that computers are there to help us work, and we should not blame the computer for our errors. According to paragraph 4 of the paper, the HA has selected some specialties for the new system. Have you include the specialty on kidney diseases? And at what point would the doctors look into the drug-related risks? At what stage would the pharmacist intervene in assessing the drug-related risks? Ms. Lee, we have initiated the clinical pharmacy services in 2 specialties, oncology and pediatrics. Because for these 2 specialties, the medicine require is more complicated. They don't have this clinical pharmacy services for kidney patients. So I'm very concerned that the omission in a prescription after giving high dose medicine to patients. And since you don't have this service for kidney patients, are we going to see a recurrence of the problems? Well, this is not really about preventing mistakes by the clinician, but this is about the interaction of drugs, or to help nurses dispensing drugs. It's not going to take over the prescription from doctors. And we have also got a special development for specialties, such as oncology. We have promoted this system to hospitals, and we'd like to seek other improvements in the system. We also have a unit to support chemotherapy for cancer patients, because there are different treatments which are very complicated, much complicated than other specialties. So you are not going to cover this system, not cover oncology and pediatrics by clinical pharmacy services. Well, we are not as advanced. We are a late starter than, for example, the U.S. in terms of provision of clinical pharmacy services. We want to cover oncology and pediatrics first, because in terms of prescription and the taking of drugs is more complicated. I'm a bit worried by Dr. Zhang's response. We trust doctors, but doctors can be very busy, and pharmacies know the drugs best. So why do you think there's no need for pharmacists to be involved in reviewing prescriptions made by a doctor? If we provide this service, we'll be able to reduce the risk. Why does the HA think this is not necessary? Well, we'll do a lot of things to reduce risk. Sorry, we have a limited time and 2 more members are waiting. This paper is on the medication order entry system for inpatients, whether we can discuss the role of pharmacists in clinical duties on other occasions. I haven't been given an answer to the question of time left. After the doctor prescribed the medicines, how much time will be needed before the pharmacist can review the prescription? Well, the clinical pharmacists work in the wards as a team. We discuss the treatment protocol. Why do we want to do this for oncology and pediatrics? Because dosage has to be adjusted for different patients, and the drug has to be prepared in a sterilized room in the pharmacies. So you are doing this simultaneously, yes. But what about specialist outpatient? Can you tell us on the monitoring process? I'm sorry, Dr. Wong, this is a departure from the paper. Maybe we can get a written response from the Bureau. I'm afraid if we ask them to give a reply, Mr. Leung Kong will have no time to raise his question. This is the IPMO system, which is for clinical services. Maybe you can talk to Dr. Helena Wong on the oncology services. How much does it cost? Does the system cost? Sorry? For this new system, how much is needed? We're going to provide supplementary information. They are promoting this gradually. You have spent $170 million since 2009. There has been a 30% reduction in dispensing errors. How much money has been spent on this? As discussed. Well, this is done in phases. I'll supplement the information later. So please, it's really regrettable. You cannot tell us how much the system cost. Perhaps you can tell us your expenditure so far and also the expected expenditure for the future. Well, I don't have the information today. Second question is, do you have an alert system? I asked this question for a good reason. There was a very well-known case that a patient was given a drug and then another hospital knew that a drug was omitted, but they were busy trying to care for the patient and they did not disclose the omission. Dr. Fan, you have already answered this. Tell Mr. Leung what will happen if Hospital B noticed something about the error committed by Hospital A? Chairman, this is not artificial intelligence. It's just about inputting information. No artificial intelligence is involved. Well, partly yes. It's not a perfect system now. Well, if we have AI, it will be different for that particular case. Well, people with high sight say the certain drugs should be prescribed at the same time. And even if the prescription is not banned, there should be questions raised by the system. Well, Dr. Pang can illustrate by an example on on how the computer can help us dispensing drugs. That's one of the functions of this clinical system. No need. There's no need. You have 2 minutes. I'll ask Dr. Pang to say something. Let me illustrate by one example. We have an alert system. If a doctor who used to be allergic to certain drugs and the information has been stored in the system, and when the doctor prescribed the same drug, the system will send an alert to the doctor to ask him to do some searches and to look into the prescription again. So this is artificial intelligence. Just like that lady, you should prescribe some medicine for the liver problem at the same time. I hope the system can alert the doctors like that. I think this is the question for another occasion. I think members, if you are interested in seeing how this IMO system works, please let me know. They would like to know the relationship between CMS and IPMO. We can pay a visit to them. It's better than talking about this in abstract. All right, I think that's it for this item. Item 7, AOB. On the 22nd of May, we have a special meeting. And on the 19th of June, we are going to have the next regular meeting. Thank you for coming. Meeting's adjourned.